computed tomography is an exciting extension of chest radiography, but nowhere has it been more fruitful than in the exploration of the mediastinum. I'm going to try and tell you in the following discussion a little bit about the normal anatomy of the mediastinum as portrayed on CT scans, with some further insights into common variants and regions of common abnormalities. Now let's take a look at this first diagram. This is a diagram of the important anatomic structures in the mediastinum that we will be considering. I want to draw your attention to the horizontal lines, which are numbered 1, 2, 3, and so on. The other numbers that you see represent regional lymph node areas, which we will be discussing in another videotape. These horizontal lines are potential areas that a CT scan may have been made through, representing a transverse slice of the body. Now, when you take a look at a scan, you may have a great series of images to look at, and you wonder where to start. Well, let's start at a familiar and convenient level. Let's look in the region of the aortic arch. Suppose we take a theoretical diagram through that region. What are the structures that we're going to use to identify the aortic arch? Well, first of all, we'll see this large shadow representing the aorta. Incidentally shown are fairly standard bits of anatomy. We see the superior vena cava displaced slightly to the right side by the prominence of the ascending aorta, and of course we will see the trachea, and also slightly displaced by the aorta, and we will see the esophagus. Those are the main structures that we'll see at this level, and that makes it rather an easy region to identify and begin the analysis from. Looking at a typical CT scan in a patient who is reasonably well endowed with fat so that we can see the structures pretty well, someone who has been given intravenous contrast material so that the contrast to the aorta and the superior vena cava are quite well marked. The aorta is obvious here. Notice that the superior vena cava shadow runs right into the aorta. This is a consequence of the partial volume effect. Notice the tracheal air shadow and the thin line of tissue just on the right side of the trachea, consisting of fat, plus, of course, the pleural surface of the mediastinum and the wall of the trachea. Notice that there is an irregular density posterior to the trachea, leaning toward the aorta. This, of course, represents the esophagus. Now, I might point out that the esophagus varies a great deal in appearance on CT scans. Sometimes you'll see it like this, with a shape very similar to a lymph node. At other times, it will have a little air bubble in it, sometimes even a double air bubble. Well, you have to adjust to that. Remember the famous rule, there always has to be an esophagus. This is the chest film of this individual, and as you can see, we were looking at a CT scan that was perhaps at about this level. And you can see on this film the shadow of the aorta that gave rise to that transverse appearance. You can also perceive the margin of the mediastinum as we normally see it on most chest films, being the superior vena cava. And if you look closely along the right side of the tracheal air column, you can see the tracheal wall shadow, which is caused by that thin band of tissue I pointed out on the CT scan. Let's go up from this level, and as we go above the aortic arch, we're going to run into the area of the great vessels. Remember, on the chest film, the border-forming region is the subclavian artery on this side. An anatomic diagram of a corresponding region above the aortic arch shows you the principal structures with a little bit of artistic license. In front of the spine, of course, you see the esophagus, somewhat patulous here, the trachea. In this case, we are still at the level of the right brachiocephalic vein, and over here, the left brachiocephalic vein, which is just beginning its course in front of the root of the great vessels. The great vessels themselves, 1, 2, 3, are the standard anatomic pattern that we would like to look for. We like to see the subclavian artery, which, as we said, will be the border-forming portion of the left side of the mediastinum high up, a somewhat smaller common carotid artery, and a brachiocephalic, or in the old nomenclature, the innominate artery. The artist, as you see, has drawn in a number of lymph nodes. These are larger, particularly these, than they would be in a perfectly normal person, but the location that these lymph nodes may be found is accurately portrayed in this diagram. What does a CT scan look like? Here is a typical CT scan in the same patient showing the 3 vessels. Now notice how large the subclavian artery looks. That may be because we are actually including a tiny little bit of the top of the aortic arch, which in the elderly is highest at this point. There also may be a slight dilatation of the subclavian artery just at its origin. Then we see the small common carotid artery, and we see the brachiocephalic artery here in the midline. There are the 2 veins to be accounted for. On the right, we see the brachiocephalic vein with perhaps a small tributary feeding into it, and running across in front of the great vessels is the shadow of the left brachiocephalic vein. Again, notice there's an abundant amount of fat, and notice that the separation of the right lung from the trachea is greater as we proceed toward the neck. Therefore, the tracheal wall stripe may appear thicker as you proceed in this direction. Here's another nice example of a variance in the appearance of the esophagus, which on this scan is seen as an air bubble with a little bit of wall around it. As we move further up, we again see the subclavian artery, very small common carotid artery. Now, since we're farther up, the left brachiocephalic vein has not begun to cross the mediastinum, and it's seen more or less end on. The right brachiocephalic vein is over here. This then would be the brachiocephalic artery, but wait, that leaves us with an extra structure. What's this? We have grown from beyond our simple 1, 2, 3 artery pattern to something extra. What are we looking at here that runs parallel to the tracheal wall, looks vascular, and is opacified with contrast material? To answer that, let me show you the arteriogram of a patient with a rather tortuous brachiocephalic artery. Picture now that we are making CT scans of this patient, and as we go upwards along the great vessels above the aortic arch, we run into a vascular structure right here, a long vascular structure foreshortened in this angiogram, which is actually running more or less from front to back. And this is, in fact, the brachiocephalic artery. We're also cutting the brachiocephalic artery at this point, as well as the common carotid and subclavian over here. As we go up even further, we may see a different pattern. We may see a long brachiocephalic artery shadow here and a short one here before we break up into the subclavian and carotid on the right. In fact, if we have a very tortuous artery, we may cut it in such a way as to see 3 separate shadows in transverse section of the brachiocephalic artery. This can be very confusing when you're looking for lymph nodes. This is the radiograph of the patient whose arteriogram you've just seen, and indeed it shows a very typical appearance of the tortuous brachiocephalic artery, making a convexity to the right of the mediastinum. If you look very closely here, you'll see a little bit of calcium in the wall of that artery. I want to draw your attention to the fact that the trachea is not displaced by this apparent mass shadow, and I think you've just seen why, because we're not looking at the contour of a mass with that kind of diameter. We're looking at a vessel which is only this wide, let us say, and it is coming at us, and that is displacing a pleura away from the mediastinum. Notice that in this particular case, you still have a tracheal wall shadow. That may not be present in many cases. Here's one more example of this. 2 different cuts from a CT scan of a patient with a tortuous brachiocephalic artery. We've got 1, 2, 3 arterial shadows, left brachiocephalic vein, right brachiocephalic vein, and a little indistinct partial volume effect. This would be the bottom of the loop of the brachiocephalic artery. If we go to the adjacent cut, we now see the subclavian and carotid arteries here. We're going further up so that the left brachiocephalic vein is heading back toward the left side. And we see 2 shadows here as we transect the brachiocephalic artery twice. Well, I hope that won't be a source of confusion in any future studies. But if you are doing CT scans without contrast material and you're looking for lymph nodes, finding an extra density in the upper mediastinum may be confusing. I want to draw your attention to the difference between that and this appearance. Here, you see a very similar contour to the right of the mediastinum. but the trachea is displaced. Clearly, this is due to a mass of this size in this region, and as you might guess, that is a thyroid mass. If we look on the lateral film, we also see that the trachea is displaced and that the mass comes down below the top of the arch of the aorta, whereas the brachiocephalic artery shadow, of course, would run into the top of the aortic arch. In contrast, just for interest, here is someone whose trachea is somewhat compressed from both sides rather than being displaced. The mediastinum is certainly widened, though the contours don't appear abnormal so far as their shape is concerned. What are we looking at? Well, here's a CT scan of that region. As you can see, the trachea has been converted into a somewhat slit-like structure, and it is surrounded by a rather dense organ, obviously the thyroid, an enlarged thyroid, which is growing down the neck into the upper mediastinum. Now, this can also be a little bit confusing if you look a little bit lower, where we see that one lobe of the thyroid has extended even farther down than on the other side. The trachea over here is still displaced. Here's a little more of this enlarged thyroid, and if we work hard, we can see the subclavian artery, the carotid artery, the brachiocephalic artery, the left subclavian vein, and some dense contrast in the right subclavian vein. This other dense structure here is dense enough and the right size and location to be a small calcified lymph node. Once more, let me point out to you a variation in the appearance of the esophagus. Here the esophagus looks like a somewhat irregular round shadow. Never mistake that for a significant mass. As you can see, once we drop down to the level of the aortic arch in this individual, we have a more normal anatomy, just a slight bit of the bottom of the thyroid lobe over here in this fat pad, a nice superior vena cava, aortic arch, and esophagus with an air bubble. Let's look at another variant of the mediastinal contour. This patient was sent to us for evaluation of the mediastinum because he had a malignancy, a seminoma, and the question was, did he have mediastinal involvement? The chest film, as you can see here, looks a little bit abnormal. There is a contour over here that does not fit our normal idea of what should be the descending aorta. Well, we turn to CT scanning, of course, to evaluate mediastinum. If you look up fairly high in the mediastinum, we see our 3 arteries, again, and we see 2 veins. Well, that looks perfectly normal so far. Let's look at the next cut. What's happening here? The right brachiocephalic vein seems to be joining the left instead of the other. And if we look at this a little bit further down in the mediastinum, at the level of the aortic arch, what do we see? We see a left superior vena cava. Incidentally, you may uncover a left superior vena cava without contrast material or CT as an incidental finding. Here you see someone with a pacemaker whose wire positioned in the left subclavian vein went on down the brachiocephalic vein, but instead of crossing the mediastinum, it went down a vessel along the left side of the mediastinum, which must be a persistent left superior vena cava. You remember, of course, that the termination of that left superior vena cava is into the coronary sinus. Here's another funny appearance in the superior mediastinum. And indeed, when you start looking at younger adults, or even children, as opposed to older people with nice tortuous vessels and a lot of fat in the mediastinum, you're going to see some funny things. Here, without contrast material, we see this rather plump shadow in front of the aortic arch, superior vena cava over here. Esophagus is blending into the aortic arch shadow. Now, the chest film on this patient was not too remarkable. This was, in fact, the cause for the study. It was felt that there was a little widening of the superior mediastinum, perhaps on this side, and a little peculiarity of the contour of the pulmonary artery over here. Not very striking findings, and you might well have regarded that as within normal limits. But having obtained the CT scan, one then, of course, is forced to interpret it. If you go down a little bit further in this patient, level of the aortic arch, you see asymmetry of this extra density. Of course, you have deduced by now that what we're looking at is a normal thymus gland. The thymus gland in the young adult is a confusing lesion. It may be an enlarged anterior mediastinal structure all the way up to about the age of 40, and therefore one cannot draw conclusions about thymic hyperplasia or thymomas unless there's a really rounded mass-like appearance to the lobe of the thymus. But be concerned about not confusing this with a significant lesion in young adults who are being worked up, say, for Hodgkin's disease. Once again, there's a little more difficulty in the young mediastinum because there's less fat separating the important structures. Now, we're back at the chest film of our prototypical elderly subject with a somewhat tortuous aorta, and we have looked above the aortic arch so far. Now let's start to move down below the aortic arch. The first thing you see, of course, is the bottom of the aortic arch, and commonly we'll see some calcifications from arteriosclerotic change there. Next, there's kind of a space in the mediastinum, and you all are familiar with this space as the AP window, the aortopulmonary window, representing a region where the lung can herniate into the mediastinum between the top of the left and main pulmonary arteries, the left pulmonary artery being indicated here, and the bottom of the aortic arch. Now, the size of that window varies with the size and height of the patient and the degree of emphysema and various other subtle things. And in the elderly, fortunately, it's usually big enough to look at very carefully. Here's a CT scan as we come down to the bottom of the aorta, and here are the calcifications within the plaques that mark the arteriosclerotic change. Notice superior vena cava. Over here, this aorta is sufficiently tortuous that it's actually come anterior and may, in fact, go so far in some patients as to become border forming on the right side of the mediastinum. Notice the esophagus, with its air bubble and tissue, have all been pulled over toward the left side by the tortuous aorta, which, as you see in this patient, is way back alongside the spine. A normal young adult would have an aorta more in this position right in front of the spine.